What is going on, guys? My name is Kenji and welcome back to my channel. Hopefully it's not the first time you're watching one of my videos, but just in case it is, I'm a doctor working in London, and in this video I'm going to tell you guys exactly what an on-call shift is like, and then I'll be giving you guys some real life examples of an on-call shift that I did very recently. Now the reason why I wanted to make this video is firstly, it's probably one of the most common questions that I get asked of life as a doctor. What is an on-call shift? What does it actually mean? And the second reason I'm doing this is that it's very unclear what you actually do as a doctor on an on-call shift. Firstly, in medical school, or at least in my experience, we didn't really get much teaching or experience of being on an on-call shift. And the other reason is that being on call often means that you're working out of hours. So you're working, after 5 p.m, you're working nights or on the weekends. And again, as medical students, you don't actually go to the hospital at those weird hours of the day. I was really confused about what an on-call shift is and how do you actually go about being an on-call doctor when I first started working as a doctor. So here is the video that I wish I had when I first started working as a junior doctor here in the UK. So the first question is, what is an on-call shift? Now, essentially, an on-call shift it's in the name, right? You're on call, meaning that you're reachable whenever someone wants to contact you or get some advice or basically get a junior doctor's help in the hospital. Oftentimes, like I said, you hold a bleep. So it's not a phone, but it's one of those really old sort of, bleep systems that you just clip to your trousers. You often hold a bleep so that when someone does want to contact you, they can get in contact with you. And you often do on-call shifts out of hours. They're often when there are not many doctors around the hospital. Usually it's after 5 p.m. So there's not many doctors on the wards, and therefore you have to be reachable, and you're the doctor that's covering multiple wards sometimes. And because it's after 5 p.m. and there's not many doctors around, you're the person that the nurses or someone needs to reach in order to get the job done. Because even though there's less work from 5 p.m, generally speaking, there has to be a doctor who's covering the wards for any sort of reason, like if a patient's unwell, or if a job needs to be done. So what does being on call actually mean at a practical level? So generally speaking, as a junior doctor, you're normally put in one of two types of on-calls. The first type is the ward cover on-call, and that's where I'll be giving you guys the example of a ward cover that I did very recently. And the second type of on-call that you normally do as a junior doctor is the clerking on-call. Now let's start off with the ward cover on-call. So what does it actually mean to be the ward cover on-call doctor? Now, as I mentioned before, after 5 p.m, all the doctors or most doctors actually go home, and there needs to be someone from 5 p.m. up until 9:30 p.m. when the night doctors come and staff the hospital at night. During that 5 p.m. to 9:30 p.m, there's generally no one on the ward to actually handle all the jobs or look after the patients. Now again, when you become more senior, you normally have to cover the ward at a different time. So like I mentioned, there are the on-call doctors from 9:30 p.m. But for what I currently do in my current rotation as an FY1 doctor is I only cover from 5 p.m. till 9:30 p.m. when the night doctors come, and I essentially have to keep everyone alive during those 4.5 hours. So what normally happens is that from 9 a.m. till 5 p.m. I'm on the ward. I'm on my normal ward doing my normal day job in my normal specialty, which right now is in stroke medicine. But from 5 p.m. I then become the on-call doctor, and I have to go and collect the bleep, which is how people and all the nurses and doctors are going to contact me. From about 5 p.m. to 6 p.m, what happens is that all the doctors who want to go home and need to go home but have an urgent thing to hand over, they then bleep me and give me all of the jobs that they haven't managed to complete up until 5 p.m. And it's my job to do those jobs from 5 p.m. until the night doctors come, and that's sort of the first thing that you have to be in charge of. So for example, again, if I'm on the ward and I'm leaving at 5 p.m, I'm not on call, I'm on a normal shift that's finishing at 5 p.m. Let's say one of my patients becomes really ill and I need an urgent chest x-ray done. I think this patient has pneumonia, a chest infection, and I need to get a chest x-ray done in order to confirm my diagnosis. Now, a lot of the times you're not able to get a chest x-ray done immediately, so it will take some time for the chest x-ray to come back. However, it's 5 p.m. and I'll be going home, right? So some doctor needs to chase this chest x-ray to make sure that, that doctor reviews this chest x-ray so they're able to actually start or change the management plan of that patient. So if I'm going home at 5 o'clock, then someone needs to chase that scan. So what they will do is they'll call me as the on-call doctor to actually chase that scan to make sure that a doctor sees the scan and I can therefore make sure the patient is okay. Now that's what happens. So from 5 to 6 p.m, I'm getting constant calls from all of the doctors on the ward, around the wards, who want to go home but have to hand over jobs. I'll give you guys an example of those jobs later on. The second way that I work on call within that ward cover role is also through that bleep. Any nurse or anyone in the entire hospital who needs to speak to a doctor and contact me. So any sort of emergency. So let's say a patient is unwell and a nurse wants them to be reviewed by a doctor, they'll bleep me. Or if a patient falls over and again they need someone to review, to be reviewed by a doctor, they'll call me because again there's no one on their ward because all the ward doctors have gone home. So I'm that person they come to from 5 p.m. till 9:30 p.m. Now from around 6 p.m. my bleep isn't going off anymore as much because all the doctors have gone home and they've handed all the jobs over to me. Around 6 p.m. is when I start doing all of these jobs and also responding to any emergencies from any of the nurses or anyone on the ward who needs assistance from a doctor. Now what I'll quickly do is I'll give you guys some real life examples of a recent shift that I had and all of the jobs that I had to chase from the day team who handed over to me at 5 p.m. So the first thing that I had to do is chase a CT of the kidneys, urinary system, the bladder of a patient. The reason being is that these doctors wanted to rule out an obstruction causing a kidney injury or kidney failure on one of these patients. So they ordered this scan and they needed a doctor to chase the scan and find out the results of the scan to make sure there's no obstruction of the renal tract of this patient. And if there is, or if there was an obstruction, then I would have to deal with that situation, like calling up the urology doctors or calling up the nephrology doctors or whatever, in order to make sure the patient is safe and managed. Now, again, I was handed over another job where this patient fell over around 4:45 p.m. They fell over and hit their head. They ordered a CT scan of this patient's head, and because these doctors were going home, they handed over the CT head results to Chase because CT head wouldn't be done now. It would be done around 7 o'clock, and someone, being me, had to chase that scan. And if the patient did have a bleed in their head, I would have to act on it and get the patient managed properly. Another job I was handed over is one of these patients was in septic shock, so they're really unwell, and they needed to be reviewed every 2 hours in order for a doctor to decide to prescribe them some more fluids to maintain their blood pressure. So this patient was really unwell, they had low blood pressure, they were septic, and it was my job to review them every 2 hours to make sure that they're not deteriorating, make sure they have enough fluids prescribed, and make sure they're not getting any worse. And if they are getting worse, I'd have to act on that. So I had 2 pages full of all of these jobs from various doctors of just things I had to chase and had to do and patients I needed to look after. Another thing that was called for by one of the nurses. So this patient again fell over and they needed a doctor to come and review the patient. So again, my bleep went off and a nurse asked me to do that and I had to go and review the patient myself. My last example to give you guys is on that same shift, this patient's catheter fell out. So a catheter is a tube that goes into the patient's bladder that allows them to wee or to urinate. And this patient's catheter fell out, and again I was the doctor who was called to replace that catheter into the patient. So hopefully that gives you guys a bit of an idea of what working as a ward cover doctor is on call. Like I mentioned, to quickly summarize, you're the doctor who all the nurses go to out of hours if they have any worries, and also you're handed over jobs that have not been completed yet. And when I become an F2 doctor, I will have ward cover over the entire night, not just until 9:30 p.m. I'll be working from 9 p.m. to 9 a.m. and I'll be that ward cover doctor again, covering the whole entire night for any sort of emergencies needed or that arise from the wards, from all the nurses looking after the patients, and also doing a few more leftover jobs from the day shift. So that hopefully covers ward cover. The second type of on-call that I have currently is the clerking on call. Now, if you're a medical student, I'm sure you know what clerking is. Now, essentially what a clerking shift is I normally start at 9:30 a.m. and I finish at 9:30 p.m. On the weekends, it varies. On the weekends, I normally start at 8:30, but generally speaking, it's a 12-hour shift from 9:30 a.m. to 9:30 p.m. Now, let's say you're a patient going to the A&E department. Let's say you need to be assessed because you're really unwell. What happens is you'll go to the A&E department and you'll then be seen by an A&E doctor. Now, the role of an A&E doctor is to stabilize you, to perform the life-saving measures. And once you're stable, if they think that you are likely to need admission, they will then hand you over to the medical clerking team. The medical clerking team is then me. It's me. I'm the doctor who's going to be coming to review that patient in the A&E. The reason why there is this shift called the clerking on-call shifts is, as I mentioned, the A&E doctors only do the life-saving things. They will give the patient the medication they need now to sustain them, to stabilize them, until I come and I review the patient again. My job as a clerking doctor on this clerking on-call shift is to go and see this patient and make sure that firstly, I agree with the diagnosis that the A&E doctor made. If I do agree with the diagnosis that the A&E doctor made, it will take some time before this patient is admitted to the wards. That can sometimes take a couple of hours. It depends how busy the hospital is, but it will take some time from the patient to be seen in A&E to then reach the ward. So my job is to be that interim doctor. So before they actually get to the ward, ward and is seen by the ward doctors, I have to come and make sure the patient's okay during those few hours. So what that involves is, once they've had the life-saving treatment, I need to make sure that they are on the correct treatment to last them the next few hours, and also the correct treatment to treat them when they actually go to the ward. I need to make sure they have a drug chart. So they have a drug chart prescribed with all of the correct medications that this patient needs to be on. That's something I also need to do. I need to make sure that they've done all the right tests. The A&E doctor has done all the right investigations to make that diagnosis. And if there's anything left over that the A&E doctor may have missed, then I then have to go ahead and request those things. So what I do is I essentially first read about the patient. Before even going to see the patient in A&E, I will read about them on the system and see, what notes they have in the system, what recent scans they have. Once I do that, I'll then go and get the notes that the A&E doctor, wrote about the patient, and I'll read through the notes. And before I even go see the patient, just by reviewing the patient's blood tests, reviewing their scans, I often have a diagnosis before even going to see the patient. Then I go and see the patient myself. I go take a full history, I examine the patient myself, and then I come up with my own diagnosis and see if my diagnosis matches the diagnosis of the A&E doctor. If I do agree on that diagnosis, then I'll just make sure they've done the right investigations or the right tests for that patient, and also make sure they've referred them to the right people. And then if I'm happy with that, I will then write them a drug chart and get them ready to go to the ward. So as I mentioned, I'm that interim period between the A&E doctor seeing the patient and then going on to the ward. Give you guys an example of something I actually had on Friday, so 2 days ago on my shift, is this patient was seen by the A&E doctor. They made the right diagnosis of heart failure, which I completely agreed with. However, the A&E doctor didn't do the full heart failure investigation kind of plan. So anyone who's diagnosed with a heart failure will need a BNP blood sample to be taken. They'll also need an inpatient echocardiogram. They'll need a cardiology review, so by a cardiology doctor or the heart failure team. Then they need to be admitted. And because the A&E doctor was just thinking about the emergency, handling the emergency, then handing them over to the, the clerking doctors, I had to come and make sure I fill in those gaps. So I make sure I order and request the echocardiogram. I make sure the patient's on the right medications to last them the next few hours until they get to the ward. I make sure they're also on the right medications once they get to the ward to actually be managed on the ward. And that's essentially what I had to do as a clerking doctor. And I do this for the entire 12 hours while I'm on the shift. Also, one thing that I do as part of my role as a clerking on-call doctor is at 5 p.m. is that I'm getting these patients ready to be seen by the consultant on what we call the post-take ward round. Essentially what that means is, for all the doctors who are working in A&E clerking like I am, every single patient has to be then seen by a consultant within a certain time frame. So normally on my shift at 5 p.m, the consultant then comes round and reviews all of the patients that have been seen by the clerking doctors on call. Then he'll make sure that the patient has the right diagnosis and has the right treatment plans before going onto the ward. So I also have to be thinking, when I see this patient, I need to prepare them properly so that when the consultant comes around on the post-take ward round, the consultant is able to thoroughly make a diagnosis and a management plan for the patient. So I then join the consultant on the post-take ward round around 5 p.m. and then I will be going around with the consultant seeing all of the patients, not just the patients I clerked myself, but also the patients clerked by other doctors. And then the consultant will write down any missing jobs. So if I forgot to add a different scan, if he thinks the patient needs to be reviewed by a different specialty, he'll do that. And then from around 7 p.m. after the post-take ward round, it's then my job to complete all of the jobs that the consultant has given me for all of the patients that we've seen on this post-take ward round. So I kind of do that from 7 p.m. until 9 p.m. And when 9 p.m. comes, I then go and hand over any leftover jobs to the night team who will make sure they're done. It's really complicated, guys, especially if you're not a doctor right now and you're a medical student. This may be kind of weird and difficult to understand, but I hope that gives you a bit more of an idea of what we do as the on-call doctors. To quickly summarize, there's a ward clerking doctor where you cover the wards out of hours. And the other part is a clerking doctor where you look after patients between them being seen by an A&E doctor and them going to the wards. And you're that interim sort of doctor in the middle, making sure that they have the right diagnosis, that no investigations have been missed, and the patient on the right treatment to go on, later to go to the ward. And that's the sort of two, on-call shifts that I do as a junior doctor on a weekly basis. Now, I hope that makes sense for you guys. Any questions you have at all, please make sure you leave a comment down below and I will get back to you. Make sure you leave a like with notifications on, and make sure you're subscribed to never miss another upload. And before I leave, here are a bunch of videos on my channel that you may find interesting before you leave. Thank you so much for watching, and I'll see you guys on the next one.